Hello everybody, and welcome to North of 60. I'm Heidi Schweighoefer. Today we're going to talk about knees and hips. I have as my guest Dr. Stephen Jackson, an orthopedic surgeon with Western Reserve Hospital right here in Cuyahoga Falls. Thank you for being here, Dr. Jackson.
Thank you for having me.
Now, first, before we talk knees and hips, how did you decide to become an orthopedic doctor? I'm really curious about things like this.
For me, it was a long trip to become an orthopedic surgeon. I was always hurt as a kid, and I was in the emergency department a lot. And every time I went there, you know, there was always somebody there to kind of help out and take that pain away and make sure everything was okay. So I went to college thinking I'm going to become an orthopedic surgeon. That's what I want to do. I want to be a doctor. And went through 4 years of undergrad and then had second thoughts about doing it, and ended up going out and teaching for a little bit and building homes and working in construction. And then I realized, you know what, I really do want to do that. So that's when I went to medical school. And even through medical school, I had second thoughts about it at that time too, because with orthopedic surgery, it's a competitive field when you're trying to do that for a living.
So I've heard.
So I ended up, I went to rotations in a bunch of different hospitals, and I found a group of people that I really liked, and the days flew by like that. So I realized, you know what, this is actually what I want to do. And I've been doing it ever since.
How interesting. When I was a student nurse, the orthopedic residents were always, frankly, cutthroat. And they were very aggressive in wanting to get in there and do the surgery. So
yes, and I think every institution that you train at is a little bit different. And what I had found where I was at my base hospital, I wasn't really excited about doing that. And when I ended up going and doing some out rotations, I really found out that there's groups of guys that you really get along with and that you have fun with, and that it's good times. So
makes all the difference.
It makes a huge difference. I may have been a family doctor or an ER doctor had I not ran into a group of 5 guys that I thought, man, these guys are really nice. And but it is at first competitive, and then everybody's there to try to teach you, to help you to learn.
Good.
So
Good.
that's part of the competitiveness, is they want everybody to be good at what they do. So.
Well, let's turn towards an older audience. All right, so over 60. Can you tell me first a little bit about what I can do? I'm 66. What can I do to stay healthy and not need surgery? Are there solutions that are not surgical? Are there solutions that are not invasive? Let's talk about that first.
Absolutely. So first, 60 and older is not older.
Thank you. Thank you.
But when we talk about how to stay healthy and keep away from people like me, from a surgical standpoint, really it's about taking care of your body, keeping our body weight down, making sure that we are choosing a healthy lifestyle as far as activity, and the types of activities that we do. So, you know, I encourage all of my patients to stay as active as possible, whether they're at, whether that is with walking daily for exercise, diet control, cross-country skiing, downhill skiing, whatever keeps you active and happy. Really, that's kind of the key to preserving your joint health and allowing you to stay relatively healthy in the world of orthopedics. So, you know, people ask all the time about programs at their local gym facility or a place like Silver Sneakers
Right.
programs, or whether they should just do it on their own. And again, it's whatever motivates you to do that is important. Keeping flexible, low impact as you get advanced 70, 80, 90. I don't really recommend running a marathon at that point, but staying on a treadmill, an elliptical, a rowing machine, whatever, gets your heart rate up, keeps blood flowing, keeps your joints loose. That's absolutely what we should be doing.
Let's say we do that and we're healthy and now things are starting to hurt.
Mm-hmm.
What do you do before you start thinking surgery? Are there alternatives to that? I know I had cortisone injections from you.
Absolutely. So when we look at the gamut of what we can do for joint-related conditions, and generally when we speak about joint conditions, we're talking about hip and knee replacement surgeries.
Right.
And that's
Right.
kind of the definitive way to
Right.
treat arthritis. We can do nothing with it at all, but there are steps that you can take prior to doing a joint replacement. And so for me, when I look at the realm of joint replacements, I mean, surgery is generally your last option. It shouldn't be your go-to option.
Good.
What I look at from a surgery standpoint is the risks and benefits of the surgery, and that's kind of what I tell all my patients. If the risks outweigh the benefit, then you shouldn't do it. If the benefits outweigh the risks, now we can talk about it. So to control those risks, again, with a healthy lifestyle, prior to doing something from the surgical standpoint, being evaluated by your primary care physician, staying in contact with a primary care physician for your general health needs is important. If you're starting to get aches and pains, you can use over-the-counter non-steroidal anti-inflammatories in limited quantities, which help decrease joint inflammation. If you've gotten to the point where you're having daily aches and pains in those joints, stiffness, pain going up and down stairs, swelling, and you've talked to your primary care physician, they may take some x-rays, or they may send you directly to either an orthopedic family physician, a more specialized family practitioner that does orthopedics, or directly to the orthopedic surgeon. From there, the use of steroids, steroid injections to relieve acute inflammation is a possibility. There are people that use something that's called PRP injections, which is platelet-rich protein injections.
Oh, I've heard of that.
Yes, those are often, but not always, covered by insurance companies. And then there's gel injections. You've heard people that
I've
have
heard of
had
that.
chicken shots or gel shots. It's really
Yeah.
viscosupplementation, and it's essentially like changing the oil in your car. You're replacing your synovial fluid that's very thin and not as viscous with a gel, and that gel basically lubricates the joint and allows you to get that knee moving or that hip moving with less friction, therefore less discomfort, less pain.
Gosh.
Beyond using those types of conservative treatments, physical therapy is a key component to getting you back to a full range of motion, full gait pattern, full strength. And if those things fail, now it's time to start talking about surgical interventions. Okay, and so when we start talking about surgical treatments, we're basically replacing the worn out bone and cartilage with metal and plastic. And so, again, we really want to try to avoid doing that if we can. That's kind of the last step. Some people progress to that, and some people progress to that faster than others. You can be in your 50s, 60s, 70s, 80s. The other question I hear, I'm too old to have a joint replacement. Well, if you're medically healthy and the risks don't outweigh the benefits, then you really are not too old to consider doing a joint replacement.
Even a person in their 90s, would you do a joint replacement? No kidding.
Absolutely. Absolutely.
That's good to
as
hear.
long as we're okay from a heart, lungs, organs standpoint.
Right.
Again, we talk about the risks and the benefits, and we have that conversation. I've gone the opposite way with patients, and there are times where you say, truly, this is not a good choice for you. This is probably not something that you should consider unless there's other circumstances. So.
I wanted to ask you very specifically about something I read about in the news about a 3D printer, I think, now I may have this wrong, being used to create artificial joints that are totally compatible with the person receiving the joint, although my understanding is insurance isn't always covering this. So do you know about that? It's fascinating to me.
A little bit. So technology has changed, and it's going to keep advancing, and we're going to keep continuing to grow. When I did my fellowship, we did a lot of surgical navigation, which was kind of the forefront to computer-generated joint replacement and computer-assisted joint replacement, or robotic-assisted joint replacement. And those are things that are starting to become more important and more available to patients as we figure out how to control the costs of that technology and then utilize it appropriately in the operating room. So there are a couple of computer-based and robotic-based systems that will preoperatively take a 3D CT scan or a CAT scan of your joint, and then that will help to customize the cuts that are used during the surgery to make everything just a little bit more precise. And there are a lot of the technologies now for acetabular components and femoral components, hip components and knee components is using 3D printers to actually make the instrumentation that's being implanted, which is really amazing to me.
I think it is amazing too.
So instead of that standard one size fits nobody, for a while, and in the mid 90s and into the 2000s, we started modifying different sizes of components to specifically fit people, and then there's always a male knee versus a female knee, and is there really any difference? With the CT generated images, it's really helping to physically make components that are going to be just like your native bone, essentially.
Do you think that's going to be the future, so that if I, in 5 years, for example, need my knee done, I would have that kind of utilization?
I do think it's going to continue to advance that way. There's
very
more
cool.
and more and more information that's coming out and being published daily from larger institutions that are using robotic-assisted joint replacements and showing the benefits not only intraoperatively but with recovery postoperatively.
Now, let me ask you about that. So let's stay on knees. The recovery periods I hear from people range, it seems like, from 2 months to 1 month to 6 months. What do you see as I know there is no standard. I know.
So everybody reacts a little bit differently. Everybody heals a little bit differently postoperatively, and everybody's pain is a little bit different preoperatively and postoperatively. In general, what we see with recovery, at least in my practice, is for the first 2 weeks after the surgery, as you may remember, you don't think it was a real good idea to do. It's uncomfortable. Somewhere between the 2 week and the 6 week mark, you generally think, if I had to do that again, I would do that. And it's usually between 6 weeks and 12 weeks where you're back to doing most of your activities.
Okay.
Now, it can take up to a year and 2 to 3 months to fully recover. But in general, most people, if they're currently working, are back to work by 3 months. If they're retired, they're back to doing their activities by 6 to 12 weeks.
Okay.
So, and again, that also varies. Are you working as a mechanic, or heating and air conditioning guy, or in construction, or are you working in a desk job? Are you working from home? All of those things kind of play into when you return to your activities
Sure.
as you want.
Do you always recommend physical therapy after surgery? I know that, again, these are just things I've heard. Sometimes I've heard surgeons will say, oh, you just follow what I'm telling you to do and you don't need to go
Yeah.
to physical therapy.
So I fully believe that therapy is key to recovery. I think doing physical therapy preoperatively is key to helping prepare you for doing the surgery. With a lot of the insurance companies currently, recommendations are for physical therapy prior to. So you've
I
had
didn't
to have
know that.
conservative treatments, including anti-inflammatories, pain medications, physical therapy, before some of the insurance companies will even authorize your surgery.
Oh.
For me, and everybody that is at the hospital, and most people that I know that are doing joint replacements, we get you up and are actively working with physical therapy immediately after surgery. So that means you come out of the recovery room, you get to your room. As soon as we have your pain under control, they have you up and moving, starting with range of motion, walking.
Literally up and out of bed that
Absolutely.
first day. Well, first hour.
First, as soon as you're able to, once you get to the
Oh
floor.
my God.
And that has changed significantly. Even hospital length of stays have changed significantly.
Yes.
We're doing a lot more of these, believe it or not, as outpatient surgeries, or a 23-hour observation where you come in, you have your surgery, and by the next day you're pretty much ready to go home or to a rehab facility. So
It's a bit daunting to think of that, but
it is, especially if you've experienced
if you're prepared.
it. But that's kind of where the trends are leading is, you can recover well at home.
Yeah, that's
provided
true.
you're given the right tools to do so. And physical therapy is one of the most important ones.
Okay. I want to talk hips.
Mm-hmm.
All right, now, everything has a story, of course, but I have a friend who is she's having her second hip replacement. She's 76. And this time she said he's doing it from the front, and so it's supposed to be completely different. This is what she's telling me on the telephone. Apparently it was different for her from the last time.
Absolutely.
So what's happening with front and back and sideways and everything else?
So there are multiple ways that you can perform a hip replacement, and there's generally three pretty consistent approaches to the hip. One is what is called the posterior approach, where you enter the joint capsule and do the entire surgery from the back side of the hip joint. There's an anterior lateral approach or a lateral approach where you're doing your surgery from the front side of the hip capsule. And then in recent years, when I say recent, 10 years or so, there's been a push or a drive to do an all anterior approach. And the difference between those surgeries is a posterior approach, an anterior lateral approach. We actually physically remove muscles from the bone and then reattach them. With an anterior approach, it's also known as a muscle sparing approach, where
that's from the front.
Correct,
Okay.
and that's where you split the muscles and you are looking directly down with the patient laying flat down on the table so that everything is just pulled to the side, and you do your hip surgery all from the front. So
No kidding.
absolutely, and that's a technique that requires a good amount of training, and there are people that do only anterior approaches. There are people that do all three approaches. I guess once you get comfortable doing a certain approach, you may stick with that one mainly. So.
Is there a difference in terms of recovery with one approach over it? Well, I would think so if the muscles aren't being
Yes.
taken.
So when we look at the 6-week and 3-month postoperative recovery of all three approaches, generally people have the same satisfactory scores.
Oh.
at that time, no matter what approach you use. With the direct anterior approach, since it is muscle sparing, patients tend to get up earlier and move quicker, and their satisfaction scores are higher at the 2-week postoperative appointment. And I don't have the numbers in my head,
okay.
but that's kind of what that push for the anterior approach was. So.
Dr. Jackson, what are the same trends that you see happening with knees, the computer what I think you called it computer assisted,
computer or robotic assisted,
and then the the new joints? Are you seeing that for hips as well?
Yes, it's not as advanced in hip replacement surgery as far as robotic assisted approach, but it's going that way. There are some developmental, I guess, people are doing them, but it's not mainstream yet.
Okay.
So it will be, I'm sure.
I hope I can wait that long. Now, let me ask you this. Are there certain things that, okay, now post-hip, post-knee, I'm doing my gardening, I'm cleaning the house, I'm doing well, I take my daily walk. Are there things you would say, just don't do anymore? Let's pretend I'm a runner or a big bicyclist or a skier. I'm none of those things. I like my bike. But, are there things that you just tell people, look, stop doing it?
I think that again goes along with the risk benefits of the surgery. It's a mechanical part, both the knee and the hip. It's 2 pieces of metal with a piece of plastic in between. And just like any other mechanical part, they can wear out with time and activities. And there are certain things we probably shouldn't do, like jumping out of an airplane or tumbling down the steps, that type of thing. But when you talk with patients who are very active and they want to stay active, the recommendation is do things in moderation, and you can continue to do them. What
That's
we're
good
finding
advice.
out is that in the past, we used to just tell people, well, come back when it hurts. And I think most orthopedic surgeons now follow their patients pretty regularly, whether it's annually, once a year, or every other year, to check in on that joint replacement with repeat x-rays, to physically make sure that it's functioning the way that it's supposed to, and x-ray wise to make sure that there's no changes from what they had the year before. Because what we're finding is if we wait until a joint completely fails, it's a catastrophic revision surgery. And if we identify problems that are building up, we can do things that are a little bit less invasive. Still surgery, but less recovery time to kind of keep that joint healthy. Kind of like taking your car into the shop for a check.
Right, for the checkup.
Yes.
We have little time, about 5 minutes. I want to just touch on something that we were talking about before we started, and that's trends in pain relief.
Yes.
I know that giving lots of opioids is not what's being done.
Correct. So this is something that's been building for a while. There's been a huge issue with narcotic use and narcotic abuse.
Right.
And unfortunately, narcotic abuse has really started to encroach on appropriate narcotic use. So what we're trying to do is make this type of surgery, it is a major surgery, a hip or a knee replacement, and figure out ways to better control pain preoperatively, intraoperatively, and postoperatively, and to use less and less and less narcotics. Now, it doesn't mean that your doctor is going to just operate on you. We're not going back to the 1800s where you get a shot of whiskey and a belt and then they say have fun.
Bite on a nail or whatever it was. Yeah.
But in a lot of institutions, we're doing pre-surgical nerve blocks. We're doing post-surgical nerve blocks where you're not physically taking the medication, but it is being administered around the nerve sheaths to quiet those nerves down. And then with a lot of the outpatient type of joint replacements, you have an indwelling catheter that slowly drips a medication to block the nerve over a period of time. Really what we found is if you can control that pain for the first 72 hours, that's surgical pain. And it does hurt. But if you can control that pain, the replacement pain, if you're doing the replacement for the right reason, is mitigated by the surgery. And so we do find that we don't need to use nearly as much in the way of narcotics. And I don't want that to have, let people be fearful of going to see or having a surgery. We still do control your pain. We're just doing it in a different way, in a more appropriate way.
I truly have heard people express concern that they would be, left out there in the cold and really.
I would fear it too.
Yeah.
So,
good.
But we work really hard at controlling pain in the most appropriate way.
Good.
And I think that's also going to advance. The farther we get into using these injections and medications, it's going to be the way that it goes.
Good stuff.
Yeah, absolutely.
Do you know our time is almost up?
Well, I had a good time.
I've had a good time too. It went fast, didn't it?
Absolutely.
I hope you enjoyed the visit with Dr. Jackson. If you have any questions about him, or if you'd like to have contact information for him, you know that you can send me an email at northof60hctv@gmail.com. Thank you so much for watching.